So this is a really interesting case where most of his cancer is actually in his liver. He's got this lung lesion. He's got a primary there as well. And you know, we do have new techniques around liver-directed therapies that are increasingly used, increasingly popular, and maybe will result, we know have a PFS survival advantage, but we're still waiting on the overall survival advantage. So the question is, who's a good candidate for that? Well, this guy's sort of on the border. He had a fairly large lung lesion. His primary is still in place. But if he has a really good response, this is one of those patients that 4 to 6 months into treatment, I'm thinking about sending him to surgery. Remove the primary. Nowadays, that's laparoscopically done. You have to hold the chemo around it. There's this evidence that says maybe removing primaries is a good idea, and you get it out of the way. It's done. And then you're dealing with this isolated lung lesion and the liver metastasis. It wouldn't be crazy to do liver-directed therapy at that point, although that might be a card I would hold till later. So we are increasingly aggressive with surgical and local therapies when patients have oligometastatic disease in these kinds of patterns. Whenever I see a brand new patient with metastatic colon cancer, it's actually a question that throws them, but I ask them anyway. I say, what do you do for fun? And they like freak out. They don't have any fun. We live in Washington, D.C. Nobody has any fun here. So, but they think about it a minute, and then I get a really interesting look into their lives with that answer. You know, it tells me about their hobbies. It tells me about how they really enjoy their time, what they do with it. And what I'm really doing there is trying to get a sense of what side effects to avoid. Because if I've got oxaliplatin, then you know, I got this cumulative neuropathy. So I got a guy right now who really likes to play guitar. He's a 70-year-old guy, and he plays in this band, and you wouldn't think to see the guy, but he likes his guitar. And so I'm going to avoid oxaliplatin in this guy for as long as I can. Others, particularly in these younger folks, are raising kids. They are driving all over the place. They are busy at work, and they don't have time for a 2-day infusion. So these are people that I'm already steering over to capecitabine as their form of 5-FU. So when you find out more about your patients, you can decide between Ox and Erie and pump 5-FU and capecitabine. We have been ignoring data for 15 years. Trial after trial had shown that left-sided colon cancers behave better than right-sided colon cancers. But we ignored it because we really didn't know what to do with that. It didn't influence our treatments. It didn't change anything. And it really wasn't until Alan Vanook, bless his heart, went back to 80405, this big randomized clinical trial, reviewed every single chart himself, not some fellow, and determined whether the patient had a left-sided or right-sided colon cancer. And then not only confirmed that left-sided colon cancers did much better than right-sided colon cancers, he transformed our practice in showing that right-sided colon cancers, even those that have RAS wild type, BRAF wild type, so the ones that are molecularly profiled appropriately, failed to benefit from EGFR therapy. And this made no sense to us. It still makes no sense to us. We thought we had the enriching molecular profile, but it turns out just being over here means that it won't work as well. So this is further narrowing the patient in frontline who should get EGFR therapy. It really is that RAS wild type, BRAF wild type, left-sided colon cancer where you would use EGFR frontline. Other studies have reconfirmed this, so this is not just 80405. A couple of other studies have confirmed it. It has now made it to NCCN guidelines. Of a little asterisk, it says right versus left. So, you know, I'm always nagging our docs in our practice to make sure you put in the right ICD-10 code, and there's a right one and a left one. And everybody says, it doesn't matter. Why bother? It doesn't matter. And I'm like, now it matters. I want you to know, we have to know which side it is. And so when you characterize a colon cancer patient now, you need to know RAS status, you need to know MSI, and you need to know sidedness. You know, whenever we set out on patients, we decide which regimens they should get. And as I said before, it's either Ox-based, Erie-based, or both. There's FOLFIRINOX with Bev in the front line. That's generally reserved for the higher tumor burden, the BRAF mutated tumor. So in this case, I would say you're between an ERI and an OX. Most of us in the United States use OX-based frontline therapy. I think that's tradition. We're used to it. One of the things we've learned early on is that you can only give so much of it because of the cumulative neuropathy. So most of us are pretty good at backing it off at a certain point. The one really strong note is if you start with oxaliplatin-based therapy frontline, you cannot get to 12 cycles. Don't do it. There's nothing magic about 12 cycles of the drug. 6, 8 is plenty, and then back off to your maintenance approach. I know a lot of docs who favor irinotecan frontline because they don't have to worry about that. They can just keep giving it as long as they want. I think that's a perfectly legitimate choice. My bias towards an OX frontline regimen, quite honestly, is that almost all clinical trials in second line use irinotecan. And so as soon as I give irinotecan frontline, those patients are now ineligible for second line clinical trials. Maybe not the best rationale for that, but that's why I do it. The second is that OX, you don't really lose your hair. And these are brand new diagnosed patients. The last thing they want, they're getting a Metaport, they're going through all of this, they don't want to be losing their hair. I know how miserable that is. So we try to put that off till later and use the irinotecan second line.